Good morning and welcome. My name is Steve DeRoges, and today we're going to be covering your START triage system. Each of you should have already received a copy of the PowerPoint presentation, as well as some sample triage tags. So before we begin, let's make sure we understand what START triage is all about and why we're going to use it. This rolls into your MCI protocols as well as the National Incident Command System. So what are going to be some of our objectives for today? Well, at the conclusion of this presentation, you should be able to understand the START triage system. You should be able to explain the system and how we're going to use it. And you should be able to apply it with some scenarios. How are we going to get to this? We're going to do our presentation. We're going to practice with the triage tags. We're going to have some simulated patient determinations. You have your questions and answers at the end, and then you have your quiz. So what is the START triage system? Well, first, START stands for Simple Triage and Rapid Treatment. It's a very simple process that was designed to treat the most people in the shortest amount of time with the best possible outcomes. All right, it's universally accepted. It's pretty much used throughout the country. So how do we use it? Well, we all know that in triage, we break patients down by priority. Green is minor, yellow is considered urgent, red is unstable, and black, well, that kind of speaks for itself. They don't need our help anymore. So who are our greens? They're patients that are ambulatory. How many of you have been taught that when you approach a mass casualty incident, one of the first things you should say is, if you could stand up and follow me, come with me? That's how we determine some of our greens to begin with. But what actually makes a patient a green? They're able to mentate on their own. They're breathing adequately and on their own, normal. We often refer to these people as the walking wounded. So those are going to be our green categories. So who are our yellows? Well, yellows get a little bit confusing because some of the things that constitute yellow, you would say, well, wait a minute, that's immediate, that's severe, that's red. But is it really? So patients who fall into the yellow category can have severe injuries, but they're not expected to decompensate for several minutes, actually up to 60. So that category can get a little bit confusing, and as we go a little bit further along, when we break down the chart, we'll talk about level of mentation, we'll talk about cap refill, and we'll talk about how we determine whether somebody is a red or a yellow or a green. So who are our reds? These are the victims that are in need of immediate attention. They're going to benefit from transport to a hospital within minutes. These are the most severely injured or ill people that we'll have, but are not to the point where they're going to tie up so many resources that they become non-viable. Remember that when we're using this system in a mass casualty incident, this is a very Darwinian process. When you do an MCI, you cannot allocate a tremendous amount of resources to one patient when your goal is to treat and keep the most amount of people alive. So sometimes you're forced to make decisions in regards to patient care that's contrary to what we would normally do. So for an example, if you show up to a motor vehicle accident and it's a minivan versus a car, there were 4 people in the car, there were 6 people in the minivan. You show up, you have 1 paramedic and 1 EMT. You're a little overwhelmed, right? Most systems that are in the area, unless you work for a big urban city, are going to be a little bit overwhelmed with those amount of patients. You have to triage appropriately. Why? Because the goal at the end of this is that the most people survive. Okay? It can get a little tedious. So who are our blacks? Well, some of those are very easy. Those are the patients that have injuries that are inconsistent with life, right? We show up and, somebody's brain is on the side. I think that's a little inconsistent with life. Somebody's decapitated. But this gets a little bit more confusing when we're talking about mass casualty incidents, because these are people that you may reposition their airway and they're still not breathing. Well, what are we taught when somebody doesn't breathe? We're going to bag them, right? But in a mass casualty situation, you don't have the manpower or the resources to do this. So those people become black or expectant. You're not going to expend the resources to try to save them. Is that against everything that we're taught when we go to paramedic school? Absolutely. But MCI kind of changes the whole dynamic of how we go about practicing medicine. All right, so some of the rules. This is the area that I told you we're going to go a little bit more in depth about, and this is helping to determine whether somebody is a green, a yellow, a red, or obviously a black. All right? The big thing is we're going to treat immediate life threats first. When you do your assessment of your initial patient, it should take no more than 30 seconds per patient. What are we assessing for? We're assessing for mentation, we're assessing for breathing, and we're assessing for circulation. So we're looking for somebody who can breathe on their own, is breathing adequately, or will breathe with a repositioned airway that we attempt once. We will try one airway adjunct. If that doesn't work, we move on. Okay? Mentation. That doesn't mean that they are completely alert to person, place, time, and event. Do they know where they are, and do they have an idea of what's going on? And cap refill. Now, typically we've been taught capillary refill in adults is really not a good indicator. We use it in an MCI scenario to determine perfusion status. So people who have a cap refill of less than 2 seconds will almost never be an immediate patient unless they have an airway compromised. Okay? So this side, it looks a little confusing. You should have had that in your handout. It breaks it down a little bit more. So everybody should have had a chance to take a look at this. But we talked about this. Your minor patients, are they able to walk? Are they breathing spontaneously? Do they have a respiratory rate that's less than 30 and greater than 10? What's their perfusion status? Do they have a radial pulse? Do they have a cap refill less than 2 seconds? Can they mentate? If they can, they're minor. We're going to walk them away, and you're going to have somebody triage them again. Why are we going to do a secondary triage? Because patients can decompensate, can't they? We may not have gotten all of the initial injuries on our initial assessment. Let's talk a little bit about expected. Were they breathing spontaneously? No. Did we reposition their airway? Yes. Were they still apneic? Yes. Then that is an expectant patient. That is somebody you're going to tag with a black tag, and you're going to move on to the next patient. What about immediate? All right. Are they breathing spontaneously? Yes, but maybe they have problems, right? Maybe they're not breathing as well as they should be. Do they have a respiratory rate greater than 30 or less than 10? Okay. What's their pulse? Do they have a radial pulse? Is their cap refill greater than 2 seconds? Now, this is where we talked about the yellow and the reds get a little confused. There should be a category here called orange because some of these are a little difficult to decipher, okay? Can you have a patient that was a yellow become a red? Can you have a patient that was a red become a yellow? Yes, depending on what interventions are provided, correct? Okay. Remember that this is a down and dirty system. This is not designed to do the thorough trauma and medical assessment that you were taught to do at the start of your program. This is a rapid intervention with the goal of saving the most amount of people, okay? Imagine for a moment the pictures at the very beginning of this presentation were from the Boston bombing. You're confronted with a massive amount of people in a short amount of time. You have a confused scene, you have people yelling and screaming, you have bystanders helping, you have trained personnel helping, you got a mess, right? And now you have to try to figure out who's who and what's what. Do you think you're going to have time to do a complete trauma assessment on each and every one of these people? No, you're not. Okay? This is why we have to use this system. So these are some examples of the commercially available tags. They all follow along with the system. Pretty simple. You're going to describe injuries. A lot of times it's a simple circle with an X, and you rip off the tag. Why do they have the tracking numbers at the bottom? Those are very important for your triage officer or your transporting officer to track the patients to know where it is that they went. Very often in an MCI, you won't even know a patient's name. The only identifier you'll have is the number from the tag. So, Jumpstart triage, we're going to cover when you talk about your pediatric lecture. So we're going to skip over Jumpstart. That is another set of assessment tools, but applies to pediatric patients. So let's do a few scenarios. Let's see how well we can triage patients. So we have a 50-year-old male with second and third degree burns over 70% of his body. That's probably a bad day, isn't it? He's got a respiratory rate of 35, a cap refill of more than 2 seconds, and he's unconscious. Well, what do you think? Is this this is an immediate, this is a yellow, what is this? This is patient's a red patient. Okay, that's an immediate patient. What about this one? We have a 44-year-old male sitting up with a dislocated shoulder. He's panting at first. Well, yeah, his shoulder's dislocated, he's hurting, but his respiratory rate drops to 20. Well, the CERT, which is the rescue teams, checks perfusion and scans for major bleeding. He has cap refill less than 2 seconds. He's alert oriented and he says he can walk. What category do we make him? He is a green category, right? What about this one? 25-year-old female with a large abdominal evisceration. She's not breathing. She's unresponsive. You reposition the airway. Nothing changes. This patient's black tagged, right? Give me a second here. I'll take a... All right. Let's try this one. This is a 76-year-old male with deep laceration to his left thigh. He has a respiratory rate of 22. Cap refill of less than 2 seconds. He's alert and oriented. What is this? Well, that's a green patient because you can control the bleeding and he can walk. Okay? 51-year-old male, abdominal pain, he has a respiratory rate of 20. He has a cap refill greater than 2 seconds. He's alert and oriented. Well, you're saying, well, wait a minute, he's got abdominal pain. It could be an abdominal injury, but remember what I said, down and dirty. Does he have a radial pulse? Can he walk? Can he talk? Can he mentate? This is a green patient. Move him along. Secondary triage will hopefully catch anything that we miss. What about this one? 24-year-old female with severe midline back pain, respiratory rate of 21, cap refill of less than 2 seconds, alert and oriented. Another green patient, correct? Yeah. 36-year-old male with neck pain. He can't feel his legs. His respiratory rate is 24. His cap refill is less than 2 seconds. He is alert and oriented. Now, what category would you believe this patient to be? He can't feel his legs. Is he neurocompromised? Yes. But is he breathing adequately on his own? Is he mentating? And does he have a cap refill less than 2 seconds? Yes, he does. This is actually a green patient. Now, maybe as you assess further and you don't have as many patients, you can move him up to yellow. But for the moment, he's a green patient. Remember, life over limb. All right? Does anybody have any questions in regards to what we just covered? Remember that this is a down and dirty, simple process. It's to be applied to the maximum number of people for the greatest benefit. If nobody has any questions, take 5, come back, and we'll have your quiz. That's it.